medial patellofemoral ligament reconstruction using a knotless femoral tunnel technique. Listed below are the authors and disclosures. Prior to surgery, a physical exam is performed to assess patellar mobility and patellar tracking. Patients with more severe patellofemoral dysplasia may present with a jumping J sign. These patients may have more severe trochlear dysplasia, patella alta, or rotational malalignment. Patellar tracking is important to examine as these patients may need additional procedures beyond the MPFL reconstruction. Here is an example of our room setup. Mayo and C-arm come in from the opposite side of the operative extremity. Arthroscopy screens are shown as well, and an additional monitor is placed over the back table to be used during guide wire placement for the femoral tunnel. The graft is prepared with each free end whip stitched on the back table, and the looped end is marked at 10 to 15 millimeters from the end of the graft. A transverse incision is then made over the patella, and another incision is made over the adductor tubercle. Dissection is then made through the skin and subcutaneous tissue. The VMO is identified and is used as a helpful landmark for future patellar fixation. The distal aspect of the VMO is a reliable landmark for insertion of the MPFL on the patella medially, with superior and inferior flaps created for later subperiosteal fixation of the two ends of the MPFL graft. A hemostat is then placed through layers 2 and 3 on the medial aspect of the knee and placed through the femoral incision. A passing suture is then delivered through those layers for later graft passage. A spinal needle is then placed on the patella for use on the lateral X-ray for location of patellar fixation. Schottle's point is then identified using fluoroscopy. A guide pin is then placed with care to ensure that the pin is in line with the femoral shaft as well as being directed towards the intercondylar notch. Care is also made to ensure that the pin is distal to the physis. Routinely, we will place the reamer over the guide pin and take a fluoroscopy image on the AP view to ensure that the reamer is distal to the physis. After the guide pin has been placed into the femur, we then turn our attention towards anchor fixation on the patella. 2 double-loaded suture tack anchors are then placed into the patella. The femoral tunnel is reamed to a depth of 10 to 15 millimeters. After the tunnel is reamed, the bovie is placed into the tunnel and used to debride the surrounding soft tissue. The guide for the anchor is placed into the base of the femoral tunnel and drilled. The knotless anchor is then placed into the base of the femoral tunnel. The working stitch is then loaded into the anchor to create a closed loop. The graft is then placed into the closed loop and delivered into the femoral tunnel with the arthroscopic probe. This is a key portion of the procedure because the graft can have too much resistance against the anchor and cause the anchor to pull out. The anchor is tightened once the graft is fully in the tunnel. Once the graft has been reduced into the tunnel, we then pull on the graft tails to ensure that there is secure fixation. Once it's been confirmed, we then pass the 2 tails of the graft using our previously placed passing stitch. We then confirm that there are no soft tissue bridges in vertical placement of the graft. To the left is an example of a graft that has a soft tissue bridge that causes the graft to track horizontally before it goes vertically to the patella. In these cases, we will pull the graft out and repass the graft. The knee is then placed on a triangle and we pull each graft tail and drape them over the patella. This sets our length for the graft and determines the location of where we secure each limb of the graft onto the patella. A provisional knot is then placed into each graft, and the knee is taken to a full range of motion to assess tension of the anchor, as well as ensuring that the MPFL is serving as a check rein with care to ensure appropriate translation of the patella with no overconstraint. The scope is then placed back into the knee to ensure extra-articular placement of the graft. Once this is confirmed, the graft is then tied definitively to the patella. A 1 centimeter incision is then made into the quad tendon, and the superior limb of the MPFL reconstruction is passed underneath the superior periosteal flap and into that 1 centimeter rent in the quad tendon. The graft is then fixed with O-vicryl. The inferior limb is then placed under the inferior limb of the periosteal flap and passed using a passing stitch through the lateral arthroscopy portal. Both graft limbs are then secured using O-vicryl. Tails of the grafts are then cut. This concludes the procedure.